episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome everybody again to another episode of our show with another fascinating guest who is helping to create another wonderful tomorrow for all of us. We are honored today to be joined by Dr. Gina Agiostratidou, who is the program director for the Helmsley Charitable Trust Type 1 Diabetes Program, which aims to advance research, treatments, technologies, and services that improve the life of people with type 1 diabetes. Previously, she was the scientific program manager at the Children's Tumor Foundation, bringing scientists from around the globe to collaborate on research opportunities in the field of neurofibromatosis, a very rare condition that causes tumors to form in the brain, spinal cord, and nerves of children. Dr. Agiostratidou has completed 2 postdoc fellowships at the Albert Einstein College of Medicine and Mount Sinai School of Medicine, focusing primarily on molecular biology and biochemistry. She earned her PhD in molecular biology from the Medical School National and Capodistrian University of Athens, Greece, master's degree in advanced molecular biology and biotechnology at the University of London, and her MBA from in New York at the Stern Business School. And his little background, the Helmsley Charitable Trust was established back in 2007 after the passing of real estate and hotel tycoon Leona Helmsley, and aspires to improve the lives by supporting exceptional efforts in the United States and around the world in health and select place-based initiatives. And the goal of the diabetes program is to improve the lives of all people living with type 1 diabetes. And they work closely with key players across the type 1 diabetes ecosystem, from patients to physicians to caregivers, ultimately seeking to improve care and ultimately prevent the disease, and have made over $700 million in grants to date. Welcome, Dr. Gina Agiostratidou, to the show.
Thank you very much. It's a pleasure to talk to you. Please ask whatever you need, and I'll be more than happy to share my thoughts.
Wonderful. Wonderful. Well, I thank you, Gina, for taking the time to come on today. Typically, we start things off just by handing our guests the floor for a little bit to talk about themselves. If you could sort of take us back a little bit to a little bit about yourself, where you grew up, how you got interested in healthcare and in molecular biology, biotechnology, and a little bit of your early career path to date. I think that'd be a great way to start off.
So, as you may understand, I'm from Greece. I grew up in Athens, and from very early, I would say around 16 years old, I had a dream to go to molecular biology, chemistry, any of this. And I was very lucky to have a teacher who really taught me and love actually biochemistry, and how basically you go from DNA to RNA to proteins and to life. And I was intrigued. So I went to England and I studied molecular biology, and then I did my master's. But then I needed to do my PhD, and I went back to Greece to be near my family. I stayed there for a long PhD. And I had this dream of going to a place that research is really unique. And I had seen only American movies and, yellow cabs and very, very high buildings. So this was my image of New York. So in January of 2001, after a blizzard, after a storm, my flight was canceled. And then I arrived in New York, and it was not only yellow taxis and very high buildings. I did as you said, my 2 postdoctoral fellowships. I deviated a bit from my PhD in the first fellowship, and I studied Alzheimer's disease. But then in the second postdoctoral fellowship, I went back to cancer. Then when I was towards the end of my second fellowship, I said to myself, I don't want to work with mice and rats and experiments anymore. I really want to do something different, and I want to do something that will really impact the lives of people. So I jumped over to the nonprofit world. My first job, it was at the Children's Tumor Foundation, where basically I learned how to be a funder and forget how to be a researcher. So I stayed there for a period of time. Then the big financial crisis in New York came, no, New York in the US came, and I lost my job. And then a couple of years after, I found my job in the Helmsley Trust. I'm at the Helmsley Trust for more than 10 years now. March will be 11. And I joined as a program officer. I worked on the type 1 diabetes program from the beginning. When I joined, I knew nothing about type 1, but I had a really huge pleasure and huge benefit to work with a person who really lives and breathes the type 1 diabetes. One of the 3 trustees of the Helmsley Trust, David Panzerer, who has 2 daughters with type 1 diabetes. And from him, I really understood the burden of the disease. So today, as you said, I'm the program director of the type 1 diabetes program. I have an amazing team, a team of great experts, but beyond that, people who are very passionate and very focused on the mission of the program.
Outstanding.
I always forget, and I don't know why. During my work at Helmsley, I did my MBA, which I think for me was so interesting because it was a different language, almost. It was learning about accounting and marketing. A scientist, that was a totally different thing. But something I really enjoyed. It gave me a different perspective and helped me basically to approach my job in a different way.
It's very interesting, and and we'll get into a little bit of the background of the trust, and then the different areas, the strategies, and so forth that you work on. But I was just very intrigued because I was looking through your publications from prior, and you did a lot of really cutting edge work in the area of cancer cell adhesion in the epithelial mesenchymal transitions. I was just wondering how much, in your experience in working with obviously a proliferative disorder like neurofibromatosis, which affects young children, is something we need to stop early, has affected sort of your strategy and thinking in type 1 diabetes, where, okay, we're dealing with something slightly different, but a similar strategy that, look, if we can intervene, and we'll get to these topics later, but if we can intervene, maybe that's the best part much earlier on to do so. I was just intrigued by that.
Yeah, I think, no, everything is connected. And I think either you study cancer, you work on neurofibromatosis, or in type 1 diabetes. I think as our knowledge, technology is increasing, we all learn, as you said, it's a lot better to prevent any disease than to cure or treat or reverse. And in something that I think the experience I had from my publications, from all the experiments I did, it was basically, if we understand how biology and how diseases start, this is, I think, where basically you can really focus and try to stop diseases. So I would say that to your question, I would say basically that, looking at the microscope, and I won't forget studying adherence and how you do a wound and then things, and then how the cells move. I think for me it was intrigued because you see there is something and there is an action, and then if you intervene during the action, then maybe you can stop it or delay it.
Let's talk about the Helmsley Trust for a couple minutes, if you would, because I grew up here on the East Coast, and I guess most people might remember, of course, Helmsley hotels and things of this nature in New York City. The trust is involved in diabetes, which you're a major thought leader in. You're also involved in Crohn's disease. I saw rural health. Talk just a little bit, if you could introduce the trust to us. Maybe a little bit. Miss Helmsley always interested in health, aside from her hotel interests. Is this sort of a quiet area of interest? And then also, if you could talk a little bit about the role of philanthropy, of venture philanthropy, and some of these other models we're seeing nowadays. You know, we've talked to people at prize foundations, some of these other sort of therapeutic contests, little different models than, say, our traditional venture capital, you know, what you put in, how you guys are impacting the different stages of development in an area like type 1 diabetes.
So it's funny that you talk about Leona Helmsley. When I joined the trust, it was actually, the trust started in 2008, 2009. I came in 2010. And when I Googled to see what Helmsley had done, it was all about Leona Helmsley. There was nothing about what Helmsley Trust has done. So it was a risk at the time for me to go at this job. But look where we are today.
Yep.
I believe we are more $1 or $2 billion, I think, in grants. Our mission, the mission of the trust, actually, 3 billion. Sorry, we are more than $3 billion in grants. In the almost 11 years we are functional. The vision of the trust has now started. Initially, there were 5 trustees. Today, there are 3 trustees. Their vision, it was always the same. It's basically to envision a world where everyone has the resources to thrive in life. And that can be through healthcare, it can be through new research and ideas, and by improving people's quality of life. And it doesn't matter where they live. Geography is not important. Socioeconomic aspect is not important. Everybody, we would like to see a world where everybody has the right to thrive in life. So the Helmsley Trust, basically, as I said, and the majority is of the funding goes to health. Our grant making for us, it's based on a few, I would say, a few drivers. One is basically to be partners with our grantees, because, you know, to cut a check and give, like, take X amount of money and go do whatever, I don't think it's enough. We need to partner with our grantees. We need to provide them with any other resources that we have. We look at problems dynamically. We're trying to be, of course, as everybody else, innovative, and we are willing to take educated risks. And this is where, basically, as you said about venture capital, how we are a bit parallel. We always have to take an educated risk. Of course, the return for us, it's not millions of dollars. It is treatments, tools, and anything else that we do. So I would say that actually one of the things that the trustees say, that we should run the Helmsley Trust, a private foundation, as a business. So we need to be agile, we are nimble, but also looking from a business perspective. If, for example, you think about a treatment, you have to think how this will become a therapy for a person with type 1 diabetes, Crohn's disease. It's very important for us to see the whole pathway. If today we found something which is at discovery stage, we need to see that in 5, 10 years, 20 years, that will really become something that will impact the life of people with diabetes, with Crohn's disease, or if they live in rural areas for the other programs, or in sub-Saharan Africa, or in Israel. So I think it's important for us that the North Star, I would say, of the program is the person. And whatever we do, this is our mind. How do we impact their lives? How do we ensure that they live a life independent, as I said, of where we live or where they live? Yes, sorry.
No, go ahead. I didn't want to interrupt you.
And I just, when we started actually at the Helmsley Trust, we went out and we talked to other foundations. And for us, I think what separates, every private foundation, if you want, is that because we don't have people who raise money for us, all right? We have an amazing investment team who is raising money for us. We have the opportunity, and I think the obligation to take, as I said, risks that they can be very long and to see the result, but also they can fail. But we are, for me, we are actually at the position that we are at really at the beginning where there is no data, and you really take a big risk. And then when you de-risk it, then you have other foundations, industry, or whomever to take over. So this is, I think, where is our position, is I would say to de-risk efforts, and then other stakeholders come and develop it further.
And that's, you know, as we talk about this quite often, sort of this valley of death that exists, unfortunately, way too often for small startups, and it's a very crucial area to be active. You know, you have the two main pillars that you've outlined in regard to type 1 diabetes. You have the prevent and delay, and then improving the outcomes. And like to start with the prevent and delay first. You, as mentioned, high risk, a high reward, but educated, investments, of course. You have personally published on areas like the primary prevention of beta cell autoimmunity, where, as we were saying earlier, starting kind of early, but also listed are things like certain regenerative therapies, immunotherapies. Talk a little bit about the different areas you work in, and then what are you most excited about? Obviously, looking at some of these really cutting-edge tools that weren't here 5-10 years ago, and looking out. What excites you most in this space?
So I can tell you about, as you said, prevent and delay pillar. So just to understand a bit more, what do we mean by prevention? So when there is a genetic risk that is associated with type 1 diabetes, but only a very, very small percentage, we will develop autoimmunity. If a person has autoimmunity, it's almost more than 2 autoantibodies, as we call them, then they will develop type 1 diabetes within a time frame. So there are, of course, the majority of the investments today from other foundations, it's more about treat type 1 diabetes and try to reverse and cure type 1 diabetes. But there is no investment in, as we call it, primary prevention, going from how do you prevent autoimmunity? Because for us, if somebody has autoimmunity, already has the disease, may not have the clinical symptoms, but you know that one day they will have the clinical symptoms. So we really focus on primary prevention. And one of, I would say, the largest investments that we have in our program, it's a platform that we have developed in Europe, a platform that performs clinical trials. It's among 5 countries, Germany, Belgium, Poland, Sweden, and UK. And the target is basically to screen newborn babies, the ones that they have the risk for type 1 diabetes, enroll them in a trial with the goal to prevent autoimmunity. So we started about 5 years ago. This platform is called GPAD. It started, as I said, 2 years ago, and we have screened already 250,000 newborns. And we screen that many because only 1% of the general population will have this risk of type 1 diabetes. So we almost have completed the enrollment of the first trial, which is a trial for oral insulin. And we will know the results in 3 or 4 years. So this is what I'm talking about, like I mentioned before, a long time. This project specific, it's about 8 years. So in 8 years, we will know that if oral insulin can prevent some forms of autoimmunity. Now we're working actively because we finished the enrollment of the oral insulin trial. We're working on a second trial that probably will have another intervention, always with the goal to prevent type 1 diabetes. This is one of the biggest investments of the type 1 diabetes program. And the other project I will talk about is actually our efforts to understand the immune system in early life.
Okay.
You know, this is again the uniqueness of a private foundation. We're talking about understanding actually not only how the early immune system develops in no disease, okay? It's a healthy individuals, basically how the immune system develops and how pancreas develops. Because it's very difficult to find a disease foundation that says, you know, I'm going to fund something that has nothing to do with the disease. I'm focusing. So we took the risk and we say, look, we're going to study pancreas development and immune development in the very early life. And of course, we will make this data available. This is one of the, actually, I would say, very important aspects of the T1D program. We believe that every data that we fund and our grantees produce under all the legal issues, all right, they have to be out to the community. We have very strong beliefs on data sharing. And actually, I'm very happy to say that the data from the genetic screening of the 250,000 newborns very soon it will be available to the community. It was a very challenging effort because, you know, there are some, in Europe especially, there is the GDPR, which is basically protection of people's data. It's very strong there.
Mm-hmm.
I don't want to talk too much about that, but I think it's important to share that the data sharing is one of the most important things for the T1D program. So we have this platform, and of course we have a lot of other projects in prevention, but also we have a pipeline that is focusing on interventions beyond insulin. We have a number of projects that focus on T-cell therapies, immunotherapies, because it has been shown in cancer, for example. In cancer, you want a strong immune system to go and identify the tumors and kill them. In type 1 diabetes, you want the opposite.
Right.
You want basically to basically decrease the autoimmunity. So we found a number of grantees, which are very early, as I said, very early in discovery, how to use this immunotherapy, the same philosophy if you want, but for type 1 diabetes. And another important project, I would say, that is another consortium, I would say, that it's really, I think, important. It's, we call it the Alpha Cell Group.
Okay.
I mean, I learned from my studies that cells talk to each other.
Yep.
So beta cells produce insulin. There is the alpha cells that produce glucagon, which basically balances the insulin. And in a person with type 1 diabetes, unfortunately, alpha cells don't work either. So you have the main issue, if you want, the main challenge for people with type 1 diabetes, it's hypoglycemia, the fear of hypoglycemia. So we work with an amazing 12 different grantees all over the world to understand the role of the alpha cell and why it doesn't work, since it doesn't get attacked by the immune system, and to identify interventions to basically make it functional. So, because in a world where the alpha cell works, then people with type 1 diabetes, and parents of people, of children with type 1 diabetes, they will sleep better in the night, because this is the big fear.
It's really fascinating, especially as you were pointing out with regard to sort of this this early understanding of the immune system, just because, you know, whether you're talking about autoimmune disorders or, as you were saying, in cancer, immunotherapy, or even everything we're hearing. You know, we've learned this new term in the last year about cytokine storm, and just all the immune system is showing itself as just such a multi-faced, multifaceted thing that, as innocuous as we may think it sounds, it's so complex that it's great that you're putting these resources into these different components of it. And we might not really think about how much it's associated with T1D, but no, it's really fascinating that you're doing that and taking those risks as well. As you mentioned, there's the second pillar that you're involved in terms of outcomes, and there's it mentions on the site how we don't think about it, but type 1 diabetes is perhaps its only disease that if we make the wrong dosing decision daily, it can have very bad outcomes, including death. Talk a little bit about what you're doing on this front, and then we talk a lot about tools on the show recently in terms of digital health, a lot going on with things like artificial intelligence as we get these devices smaller, smarter, and so forth. Any interesting tools on sort of that front as you think about managing outcomes in 2021?
So the other pillar, we call it living with T1D. Okay. And the living with T1D, I think it's something that has developed as a team. We have developed this approach, if you want, the last couple of years, because we discovered that by solving, like, you have better technology, or better devices, continuous glucose monitors and better pumps, you think, oh, that's fine. It's not, because then there are about more than 30 factors that actually affect how glucose gets regulated in your blood. And we measure only one, glucose, right? So how you manage your diabetes, we measure one thing, but there are another 30 things that influence your glucose, and we never measure them. So we have many projects. One part of the Living with T1D focus on, as I said, on devices. Actually, initially, we focused a lot on continuous glucose monitors, but now we are moving more on adoption of these devices, because it has been shown that using CGMs, the clinical outcomes of people with type 1 diabetes improve, but only very few using it. And, there are the usual roadblocks, reimbursement, education, and all this to become adapted. So we work actually towards adoption. One highlight I would say there is basically, as I said, we measure only one factor that influences glucose. We actually have a number of projects that focus on additional signals. Signals like how your body changes when you exercise. When you exercise, like you go out, you run, just for a morning run, or you compete. All these things are stress. There are so many things. So basically, we're using now, we have a number of projects that focus on additional signals. We have a big study that really focus on exercise and how exercise affects glucose management. And again, it's about 800 people who are enrolled in this trial. And the data from these people, again, when this study is complete, they will be available to the community. The other part, if you want, of Living with T1D is what you said, is about technology. We focus a lot on telemedicine.
Okay.
We have a project that's called the T1D Echo, which it takes place in Stanford, in California, and then in Florida. And these two hubs, they connect together with health centers, federally qualified centers, who basically people there don't have access to endocrinologists. So people who go to these healthcare centers, their doctors or their health providers can connect to the experts in Stanford and Florida and learn about type 1 diabetes and any questions they have. we have shown, I think that's an amazing project. I went actually to California, and we went from, now I'm not very good in geography in the US, but from Sacramento up to San Francisco. And we saw places that they told us there is no endocrinologist. Like, you have to go to San Francisco, you have to drive 3 hours to go to see an endocrinologist. So if I have type 1 diabetes, how I'm going to get my prescription? How I'm going to see? All right, what do? You have to go to a PCP, to a general practitioner. Who, I mean, I can ask every doctor, to know about type 1 diabetes, about type 2 diabetes, about all the diseases. So it's very difficult for them to know. So the T1D Echo, I think it's really impactful, and it's using this telemedicine basically to connect with other providers in places that they don't have access to endocrinologists. Technology, I think, sorry, yes.
No, please, keep going.
Technology, I think, it's something that's really important to us, and artificial intelligence. We actually funded for the second time. We fund a hospital where basically they have a lot of data through EMRs from the clinic, and we're using a company that is using artificial intelligence and machine learning that is able to take this data and predict who is going, to have a diabetic ketoacidosis, who is really is at risk for several really things that this should not happen to a person of type 1 diabetes. Artificial intelligence, I think, for us is the next thing that we want to use. But where is, I think, for us our challenge is, as of today, every hospital has a different EMR, and there is no way to come and make them all, the same, so that when a machine comes, has the ability to compare 100,000, 1,000,000 people with type 1 diabetes, and even not even with type 1 diabetes, people with type 2 diabetes who receive insulin.
Yep.
So artificial intelligence is important. And the other part, if you want, of the portfolio that's thinking about digital work is the following. The data, the continuous glucose monitors, they measure glucose every 5 minutes. So the breadth of the data, it's really huge. So there is a company, actually, it's called Driamed, that it's out of Israel, that they have developed software who can take the data from the CGM and make recommendations, actually. What do you do next? How much insulin to take? Or it gives recommendations of how to manage your type 1 diabetes. Of course, all of this is it's not out, all right? It's all within trials and studies. But I think that's the future, because as we all know, the number of endocrinologists will not increase in the future. And you need to find alternative ways to provide quality care to people with type 1 diabetes and anyone. So I think the digital tools and artificial intelligence are very important, I think, and they can provide quality care to anyone wherever they live.
And leveraging that thought, the Helmsley Trust supported this Lancet Commission report, I think it was last year. You wrote a really nice article recently in DevEx. It was entitled "COVID-19 is the epicenter of the bigger health earthquake, non-communicable diseases." And you talk about sort of these comparisons, how COVID has gotten us looking at these important items, namely, as you were saying, if we have no endocrinologist within 5 hours, we need non-specialist folks that can take care in this decentralized thing. We need to understand patients better, as you were saying, when we look at these large populations. But then you also talk about the social determinants of health. And this is a very important theme that we've heard a lot about lately. If someone with diabetes can't afford their lunch, it makes it difficult to give them a quality of life. Talk through this, the Lancet report, if you would, involved in that, and then please just walk us through. I think this is a very important article that you wrote.
So I'll tell you I'll start with a story. First of all, this global access portfolio that we have and supports the Lancet Commission and many other projects, it started about 6 years ago, and it was started by a program officer. So we funded Partners in Health, which is a big organization, NGO, to basically decentralize health in Rwanda and Haiti. And then when I became the director, I thought to myself, we have given millions of dollars to these people, but what do they really do? What means decentralize, right? And why people cannot go to the hospital? So we took a very naive and stupid, I would say, thought. But we went to Rwanda, and we traveled up and down the country. And I met a guy, young person, 18 years old at the time, that it was about 4 years ago, who basically, we met his family. And we said, how did you get diagnosed? It was because there is a healthcare center 5 minutes away from my home. And the Pen Plus, which I'll explain to you what it is, there is care for me. When I went with diabetic ketoacidosis, they knew what to do. So, and then his dream, it was actually to become a nurse and help other people with type 1 diabetes. And that meeting made us increase our investment in the global access, I would say more than 50%. And we expanded actually really our global access portfolio. And one of the main, I would say, priorities of the global portfolio is the strengthening of healthcare systems. And strengthening of healthcare systems, I mean, it's what we're discussing today, because you have even the US and Europe, all right, where basically systems have a lot of challenges. So imagine that when you go to Rwanda, there is one hospital, and people from anywhere they live in Rwanda, they have to walk or take a bike or a motorbike to go to the hospital. So this project with Partners in Health, it's basically the development of a clinical model called Pen Plus, which has the ability to treat a number of diseases: type 1 diabetes, sickle cell anemia, rheumatic heart disease, and be decentralized from the main hospital to district hospitals and then to healthcare centers. So basically, every person has access to healthcare. And this project now has expanded to Malawi and Liberia. The Lancet, that we were approached by the PI, Dr. Gene Bookman, who is the PI of the Pen Plus project, and he said, we need data. We need to know what is the burden of NCDs in the poorest billion globally. So he identified people in different countries, people who understand that. And after a long time, they developed this amazing report that I think people have to read it just to understand that when we talk about non-communicable diseases in the setting of the poorest billion, that actually means death, all right? So the reality is when we went to these countries, we met nobody who was diagnosed below, I would say, 10 or 12 years old. The type 1 diabetes gets diagnosed. You can be diagnosed at 6, at 7, at 8. What does it mean? Or it's either another disease, or these children actually die because there is no care. So what Lancet did, it created the data that says basically that you have 800,000 deaths annually from NCDs, And most of them, they're people less than 40 years old. And that basically destroys financially because people have to pay out of pocket.
Yeah.
So it's not that you have only lack of access, but then you have a financial burden that it's beyond, right, beyond understanding. And for us, what I think this showed that every data point you have in there, it's a person.
Yep.
And this is the way I think everybody who reads it has to think about the importance of this. And I think having the Lancet, this Lancet document, it is the baseline. And then using interventions like 10 plus is basically how we can help improving what is our really sad baseline. And that was, I think, the importance of the NCD, of the Lancet. The other aspect I would say is that, you can provide the best healthcare, but if a person with type 1 diabetes does not have food on the table,
Yep.
doesn't mean anything. So we're working actively with another foundation to identify ways to help people with not only type 1, with chronic NCDs, they can have access to improve their skills on agriculture and actually make them sustainable, all right? Be sustainable, and they can basically bring food on the table as they have care to quality care. And that, I think, all talks to the vision of the trust, if you want, that we need to provide all the resources for people to thrive in their life.
And as Gina, you talk about obviously that billion poorest. I just have to bring this up because I come out of the pharmaceutical. I don't work in the pharmaceutical industry anymore, but I spent a lot of my career there. We forget that insulin was created. It was before penicillin. It's been around a long time, and what are we seeing nowadays? I mean, we're seeing just the ridiculous, pricing on this. I mean, obviously that was the porcine and the bovine types, but I mean, we've genetically engineered this stuff for 40 years now. Anything you're doing on sort of the price control front or the research of why here we are in 2021 and insulin is through the roof?
Yeah. First of all, now this year you will celebrate 100 years of the insulin discovery.
Yep.
I think from our view about the industry and the pricing, I mean, we agree. Insulin is a drug that if you don't take, then people just die. All right? No insulin, no life.
Yep.
So it has to be available to everyone. Actually, I have to say that we support a donation program together with Lilly. Lilly is providing insulin to a program which is called Life for a Child, and they touch thousands and thousands of children globally. We believe, on the other, I agree with you, the insulin is to the roof. On the other hand, an industry has to have the money to continue innovate. All right. So I just think the problem, I don't think for us, maybe yes, the insulin is expensive, but beyond the time, the price that a company has for insulin, there are so many other players. Then the price becomes really high. And we saw that even in developing countries, all right? You have tariffs, you have taxes, that the price of the insulin, human insulin, which is very cheap, it goes from, I don't know, $1 gets down to $20 because there are so many middlemen in there. And then you see this a lot in developing countries. And we have actually a project, they call it the ACES project, that really focused on identifying why the price of insulin is so expensive, is so high in developing countries. And I agree with you. I mean, insulin should not be expensive. It's a drug that you don't have it and you die. but I think it has to be a balance, because you don't want these companies to go away. Okay, so you want to make sure that they continue innovating.
This is true. This is true. Gina, obviously we're here at the beginning of 2021. We're still, you know, hopefully coming out of this pandemic soon. Any conferences that you're going to? Any specific stuff coming up in the next couple months that we should know about? So that whether it's on the diabetes front or other activities for Helmsley that you're going to be out there talking about?
You know, everything now is virtual, so I think that's something. It has these benefits. I was in a conference that, you know, we're supposed to do it during the UN meeting in New York, and we're expecting like 150 people, but we did it in virtually, and it was like 2,000 people.
Ooh, nice.
So I would say a couple of things that they are happening. Of course, it's the American Diabetes, the American ADA, the American Diabetes Association conference that is happening. We present sometimes, but not very often. I would say that the meetings that I participate, they are more now lately on the global efforts, and there is a number of actually meetings that brings different stakeholders to think about solutions for NCDs.
Mm-hmm.
I would say that in the fall there will be a meeting that actually focus on alpha cells, that it will be probably open to the community, and whomever wants to participate, they will participate. But to be honest, I cannot tell you much, because I do not know what is coming up. That's the reality, is that the world is upside down a bit.
Understood. Yeah, we hear that on all fronts. Gina, just one wrap-up question, sort of, you know, coming back to you. Obviously, you've been involved in some fascinating areas now in terms of diabetes, the Tumor Foundation, obviously all your work in biotech, molecular biology. Take a little time, if you would, just to mention, shout out to any important mentors, influencers along your path, whether from academia, from the venture community, from philanthropy communities that have been extremely instrumental in keeping you focused and moving along this path. Take your time on that one.
So I was starting from very early. As I told you, from 16 years old, I wanted to go into biology. And I had one teacher. So I was trying to learn organic chemistry. Organic chemistry, it was very difficult at the time. And I continue failing and really very, very bad. And he told me that, you know, you have to sit down and really start from the beginning and start building and building. And I think it was embarrassment, because I failed miserably. But also it was like him telling me how to do it. I have to say that I was so good in organic chemistry at the end, after a year. Like the tests I was given, that would be all A's and A+. And that, I think, it opened a bit, it's the way that you become a scientist, all right? You sit down, you think the problem, you think it through, you think all the possible outcomes. And that, I think, it helped me, organic chemistry, the methodology, if you want, and how methodic it is. It helped me a bit to become a better scientist. And I would say that for me, who really has, in these 11 years of the Helmsley Trust, who has really inspired me? I think, as I said earlier, is one of the trustees, David Panzerer, who, you know, he told me about 2 years ago, he was on vacation, and he sends me a mail saying, you know, my second daughter has type 1 diabetes. And As I told you earlier, I have a 2-year-old daughter.
Mm-hmm.
It made me understand. That's the one phrase and the way he said it. It was just for me what it means to have type 1 diabetes. And I would always turn actually to him to understand a bit, to understand. I don't have type 1 diabetes. Nobody has type 1 diabetes in my family. For me, it is really inspirational, and always think that whatever I do every day, it's about helping the people with diabetes. His daughter, and everyone was type 1 diabetes. And that was, I think, if it was not for him, I'm not sure, if I would really think about the people who we serve.
Mm.
Because as a scientist, all right, you focus on your little thing that you do, and
Right.
it never translates to people. When you are in your lab, you're getting excited because your experiment worked, but means nothing, okay? It's probably it is for the pathway for somebody to get a therapy, but it's so removed. So I think having the people around me who remind me why I do what I do, I think that is really instrumental to me.
And that's yeah, I think, and I've seen you talk about it in other shows about the data, and you said it earlier, these data points. That's not just a data point, that's a person,
Mm-hmm.
that's a
Yeah.
life. And I think that sums it all up. And I really, I appreciate that message, and appreciate you sharing that with us. Gina, it's fascinating portfolio of opportunities and programs that you're involved with, and it just really wishing you the best with all of it and moving it all forward. For everybody that's going to be listening to this particular episode on the podcast or watching on the YouTube channel, you've been listening to Dr. Gina Agiostratidou, Program Director, Helmsley Charitable Trust, Type 1 Diabetes Program, advancing research, treatments, technologies, and services to improve the lives of all people with Type 1 diabetes. Gina, I want to thank you for taking the time out of your schedule to come talk to us for a little while about what you're doing. I want to thank you for doing it. And as we say on the show, thank you for helping to create a better tomorrow and a better future for everybody. It's very inspiring listening to you. And just once again, thank you for doing it.
Thank you so much. Thank you for broadcasting our ideas. That's really amazing for us. Thank you.
Absolutely.